Test one, two, three. One, two. Check, check.
Oh, that's great. You got it on here. We're going to go ahead and get started with this special CME lecture update on CD19-targeted CAR T cell therapy to treat severe refractory SLE. And Joan Merrill's going to give us this talk. Joan.
So to remind you, this is a special CME talk, but it's been merged with the CME that you get for the whole meeting, so you don't have to go to some new place and do new things. It's supported by an independent grant from Bristol Myers Squibb, and the activity was organized and provided and vetted over by academic CME. And so this is an accredited situation, and again, fortunately, it's been able to be kind of merged to a great extent with the CME that you already signed up for, so you don't have to sign up again. Here are my disclosures. And I'm going to pause if anybody wants to get the pretest. You just lift up your phone and scan. And then there's going to be a post-test, and then that's how you get the CME for this. So I'm just going to wait a minute. If I had one of those systems that plays Jeopardy music, I would play it. And if I could sing, I would sing. Okay. So here are the learning objectives, and we're going to start the talk. References. I would like to describe a case of a 38-year-old woman who had had SLE for a number of years. This is a published case report, so it's not my patient. This patient had had proteinuria in the past and arthritis, and was from a part of the world where they don't necessarily always do renal biopsies, but I think we should assume that something was going on in her kidney in the past, but it had improved with standard lupus treatments. And she also had refractory thrombocytopenia. Her platelet counts were consistently between 10,000 and 20,000, despite treatments with all kinds of immune modulating agents, including pulses of methylprednisolone, hydroxychloroquine, IVIG, tacrolimus, cyclosporin, sirolimus, danazol, and a thrombopoietin receptor agonist, as well as recombinant human thrombopoietin, and finally had achieved a temporary response with rituximab, which of course is an anti-CD20 that depletes B cells. And it's sort of an earlier generation of these that we've used widely in lupus, but may not necessarily have the deepest depletion compared to some of the others. And so that was okay. And then, as you know, with these patients, we're not treating them all the time. We kind of wait and watch. In this case, she really, 20,000 would be a good number for her. But in 2023, she presented with purpura, widespread ecchymosis on her limbs, gingival bleeding, and it was not so good. So they did a bone marrow smear, and it did show active myeloproliferation and impairment of the maturation of megakaryocytes, consistent with the immune thrombocytopenia of lupus. Now, the pathogenesis is multifactorial in lupus, so there's excessive platelet destruction from autoantibodies, but there's also suppressed platelet production because the megakaryocytes are not working so well. But the platelets that do come out, needless to say, given the environment that caused the destruction in the first place, they're activated. And platelets have a lot of receptors on their surface that are a lot like some of our adaptive immune cells. So they get revved up by the very process that's trying to destroy them. And so, it's kind of a complex picture and really complex thinking about how to treat these patients who are quite refractory. I'm going to pause and just say to you, I don't know how many people here have had that many patients with refractory immune thrombocytopenia, but there is a subset of those patients, and this is fairly rare, but it's certainly seen, and I've certainly seen it, where they can live for years with platelet counts of 30 to 40 and have no problem at all. And those patients don't necessarily need to be treated at all once they stabilize out. So there is a condition that's kind of like a low-grade chronic grinding out and building up that just seems to reach an equilibrium that's fairly safe. What we don't know about those patients is the risk-benefit ratio of constant immune modulation versus allowing that sort of low-grade inflammatory syndrome to continue for years and years. We certainly know that cardiovascular disease in allegedly healthy people, although most of us are too fat, but anyway, like me, allegedly healthy people, the chronic inflammation is associated with metabolic syndrome and bad cardiovascular risks. So I think we have to kind of assume that may also be true for those refractory but stable autoimmune patients. In this case, we have a kind of clear-cut case of a patient who gets in trouble. And because this patient gets in trouble, something had to be done. Now, the risk factors for this kind of patient include pregnancy. So sometimes patients with pretty stable thrombocytopenia will go out of control during pregnancy. If you see autoimmune hemolytic anemia, that's also a sign that this patient may get into a lot of trouble. It's not a good sign if you see decreased complement C3, although in lupus we see that, with or without this condition. And the severity of thrombocytopenia when it gets really low with platelet counts down to 5 is a marker that this could be a very refractory patient. Also, the higher your anticardiolipin antibodies are, the more risk you have that this is going to be a chronic condition. And it really overlaps with a kind of a thrombocytopenia of the antiphospholipid syndrome. So there are key roles of some of the autoantibodies that we're familiar with from lupus, as well as some special antiplatelet antibodies that sort of come and are seen in also in the immune thrombocytopenia that the hematologists think are not lupus. I'm not sure I agree with that, but without other features of lupus. So some of these antiplatelet antibodies are targeting adhesion molecules on the surface of platelets, such as an integrin molecule, GP2B3A, and it causes platelets to clump and stick together, and also 1B2A. And platelet factor V is seen quite a bit as well. And then, so they're antibodies to platelet factor V. It sort of gives you a diagnostic in to thinking, okay, this is immune mediated. But also lupus anticoagulant and antiphospholipid antibodies are very common in this condition. There are also, of course, with lupus going to be a high incidence of other antibodies associated with lupus. And you see RA antibodies, and you see thyroid antibodies, and you see that spectrum of antibodies that we just are kind of familiar seeing in many of our lupus patients. So rituximab is actually used quite a bit in this situation, and is at least temporarily effective in maybe 60 to 70% of patients, including refractory patients. About 20 years ago, there were just massive numbers of case series reported, primarily from Europe and primarily from hematologists. And we became aware of it, and I think ever since, rheumatologists and their collaborative hematologists have been using rituximab for refractory thrombocytopenia. But most, or half at least, of the patients who are treated with rituximab will go ahead and relapse once the rituximab is gone and the B cells come back. So it may not be something that's going to give us long-term remission, and it leaves us open to new ideas. And of course, the new idea du jour is CAR T cells. So the idea is that you would put the target recognizing feature, the antibody's business end, right on a T cell. So instead of an antibody sort of showing up and having its FC receptor maybe, find an immune cell somewhere in that and get that immune cell to ingest or destroy the target for the antibody, that, it's already on a T cell, and the T cell is a killer. And so you're literally seeking out all of the targets for this antibody, and in this case, we're talking about antibodies to CD19. So our goal is to find the B cells and kill them. And it's, of course, having worked with rituximab and other B cell depleting agents, we rheumatologists are not as scared of that as maybe we would have been 20 or 30 years ago. Because it turns out that within a reasonable amount of time, those B cells get regenerated and come back. And what's hoped with the CAR T cells is that if you could somehow get enough of them, that when they come back, they're not going to be carrying all the baggage of those old B cells, and we may be able to start fresh. And this is a term called reset of the immune system. But I do want to stress that reset of the immune system is a manufactured idea because our immune system is constantly resetting. In healthy people, our immune system is constantly resetting. We're constantly using various feedback loops and mechanisms in our complex immune system that will come in and say, okay, everybody calm down, that virus is gone now. So let's cover up the antibodies to the virus with other antibodies. Let's ingest the kind of waste that's been left in our bloodstream that's causing and triggering more immunity. And let's just start over. And when a new organism comes in the body, it may not even want any of that mechanism. And we got plenty of B cells here, plenty of naive B cells here, and they're going to start fresh with a new immune response that's not all cluttered up by the old immune response. Of course, in lupus, it is cluttered up by the old immune response. So the idea of the CAR T cell is we'll get back to that. But there's some intrinsic issues with assuming that that is necessarily going to happen, because something got them to lupus in the first place. And if you didn't develop lupus until you were 36, maybe you could hope you could get 36 good years, but there's a lot of training that has gone on, and not just with the with the B cells. It's gone on with T cells, and certain recognition antigens are still there on other types of immune cells, and even in some of the cells that are on the targets that the autoimmunity is targeting. We know that's true in the kidney. So I think it's a little bit optimistic to think that we're going to completely reset the immune system into that of a healthy person, because there are forces at work we did not get rid of, no matter how many B cells that we kill. Nevertheless, I'm going to foreshadow what I'm about to tell you. There have been some dramatic case reports from the first lupus patients who've received CAR T cells, suggesting that there are patients, and quite a few of them, who receive this therapy and go on into a deep remission off all other drugs. And that's the goal of what's being done here, to see, can we just get them off all these awful toxic drugs, get them off everything, and have them stay healthy, and for up to 2 years and more. So yes, this is exciting, and all the poo-pooing I'm going to do because it's my job. We have to be critical, and we have to go forward with our eyes open. I'm going to say underneath all of this, we know that there are some patients who have already received surprisingly dramatic results with these, and that's very exciting. So here we are in that little picture down there. You see the T cell is like reaching out and hitting CD19 on the B cell, and that T cell is going to get revved up, and it's going to ingest it. And a monoclonal antibody, on the other hand, is going to have to also find that target antigen on the B cell. But then, it's sort of got its tail hanging out, waiting to find an immune cell to come and help it kill the B cell, or somehow rev up and get cytokines going to kill the B cell. So we already do know that in refractory B cell leukemia, CAR T cells seem to be able to induce a more profound remission than rituximab, which is a staple drug for many years in that condition. What we don't know is, will that be true for immune thrombocytopenia and or refractory lupus? And that's what we're working on right now to try to figure out how many patients, which patients, in what way could this be a unique and effective approach to treatment. Now, I'm going to go back to being critical, which is our job, all of us. We have to be critical because doctors may be the last people in the United States who are critical. So it's up to us. Is less always more? And is more always less? And that's a question that I think we should be asking ourselves all the time. In the case of CAR T cells, the assumption is, at least for some patients, and the data supports, at least for quite a few patients now, that more is more. So on the left, you have a graph showing the difference in B cell depletion. In orange, we have obinutuzumab, which is an antibody depleter, but it depletes better than rituximab. And on the bottom is rituximab. And it's just showing you that there's a greater percentage of B cell depletion with obinutuzumab. But overall, I showed you this morning the data from nephritis trials where it's not that convincing that the percentage of patients who improve is necessarily that much more compared to placebo with obinutuzumab versus rituximab. And you know, the rituximab trials originally failed. There are lots of reasons for that. We weren't that good at doing clinical trials in lupus and tapering steroids fast enough and handling, you know, sort of the management of the data back in the day. And the more modern renal trials are working a little better because kind of know how to do them and how to get the placebo responses down low enough so that the treatment responses can be interpreted. It's still unclear. Is this really a better drug or isn't it? And yet, within the patients who take rituximab, those with better B cell depletion do seem to be those more likely to respond. And within obinutuzumab, they found the same thing. So, you know, I think the data are out for individual patients. We don't know the degree of B cell depletion that's necessary for an individual. And I just want to point out to you again something I showed earlier in the meeting on the right-hand side, that we have had many, many trials in systemic lupus. And these are just illustrating some of the more recent ones, but there have been many more where, for example, on the left part of that right graph, you're looking at results from an anifrolumab study. And you can see that there was a dose that was more effective, which was the maroon dose, the people represented by the maroon bar, and we're looking at the percentage of response compared to the placebo in gray. And that maroon group seemed to outperform the dark blue group, who received a different dose of anifrolumab. And that was a higher dose of anifrolumab. And if you look at data from recent phase 2 studies of deucravacitinib, you'll see that they found the same thing. The lower dose worked better than the higher doses, and there was more of a percent response. Now, in thinking about an individual patient, though, does that mean that all patients would do better if they got the lower dose of the drug? It may not mean that, because the people in the blue group may have needed the higher dose. In fact, if you thought about how do I account for all of the patients, you might have been able to stack that blue group on top of the maroon group and you still wouldn't have gotten to 100%. So it could be that many, if not most of the people in the blue group actually require the higher dose. And it could be that some, if not most of the patients in the maroon group wouldn't have done well on the higher dose. They would have been above there with all the non-responders, above the top of the bar with all the non-responders. And so that is something we have to keep in mind and not let go of just because we find a drug that works better. Because so far, and I'm sorry to tell you this, despite all of the excitement, even CAR T cells are not working great for everybody. So we have to think as clinicians about the individual patient and really consider that, and I have said this before in this meeting, and I will unashamedly say it again, until we get the kind of sophisticated biomarkers that can help us guide dosing like 21st century, captains of the starship, we really need to go back to very fundamental pharmacology and biologics that keep getting approved at one dose because it's the least dose that's most effective, may be disenfranchising some proportion of our patients who might have responded to a different dose. So let's push for that and go back for more flexibility in dosing, even with biologics, because it is not true that one drug fits all, and it is not true that one dose fits all. And we've been learning this again and again and again. So we have several generations of CAR T cells now. And the difference is that originally, first it was sort of a simple idea that you would just put the part of maybe an antibody that's going to recognize, and in our case, it's CD19, which is ubiquitous on B cells, because we're going to target the B cell. You just put it in the T cell and see what happens, and there was some efficacy there, and it was quite exciting. But in the oncology world, when they started using this, they realized that the cells didn't live forever, that sometimes the cytokine release, especially the good killer cytokines that they wanted to use to kill the B cells, wasn't as great with these manufactured cells as it might have been, in vivo. So they started adding other accessory components to these CAR T cells. And so we got the second generation, and then we got, now we have several more generations where they're adding all kinds of bells and whistles to these cells to make them live longer and kill better. And that whole world is very exciting and very interesting. But in this case, in the case of our patient with thrombocytopenia, we're going to be talking about a second generation. So it's a little bit more tough than the first generation, and maybe not quite up to date with some of these brand new CAR T cells. Now let's go back to the fundamental idea about what's going on in these patients. This is a classic example. Immune thrombocytopenia, classic example of sort of very classic B-cell mediated autoimmunity, which is instigated by elements of a innate immune response. It's sort of transitioning into an autoantibody-mediated immune response, which is an adaptive immune response. So we have a plasmacytoid dendritic cell, which makes quite a huge percentage of the elevated type 1 interferons that we see in lupus patients. And so that's at the top of this picture. And those interferons go out and activate T cells and myeloid cells, and of course B cells directly through, for type 1 interferons, there is a single receptor that seems to be on all of these cells taking in those signals. Now, lots of things are going to happen. The B cell is already getting revved up to begin to develop an adaptive immune response, where it's running around picking up these invaders into the body, which turn out in this case to be our platelets, but pieces of platelets, and it's going to be presenting this to the T cell, and the T cell is going to be giving permission, going to create a permissive environment for those B cells to become enraged, begin to target and seek out and ingest these antibodies. Oh, they're doing the same thing with the myeloid cells. The macrophages are running around doing bad things too. But what the macrophages are also doing is they're revving up the B cells. They're making copious amounts of a molecule you are all familiar with, because that's the target for belimumab. It's called BLIS, and sometimes it's called BAF. And we have to all get used to the fact that sometimes it's named BAF and sometimes it's named BLIS. Because there's just an awful lot of literature out there that we need to master, and we're beginning to get a little better at figuring out how this is all fitting in. So the macrophage, or the monocyte, or the neutrophil, which is also a myeloid cell, are making a whole lot of bliss, and that bliss is causing the B cell to survive and differentiate, and that's when you get your full adaptive immune response. And those B cells transform into plasma cells. First they become plasmablasts, and they become plasma cells, and they also make their own cytokines that add to the trouble. And of course, the plasma cells are making antibodies, and those antibodies are causing a great deal of inflammation and instigating even more trouble. Eventually, the pieces and bits of those antibodies and immune complexes that form between those antibodies all clumping together, as well as sometimes they'll clump around their antigen, sort of like a porcupine, all sticking around the antigen, and that's a really classic immune complex. They're all going to get ingested by that dendritic cell up at the top. And there are also some pieces of dead and dying immune cells, and we call those CpG peptides, and they're just primed to go into that dendritic cell and say, hey, we're in trouble out here. We got to do some more. We got to do some more things. We got to get that army. We got to get some more troops. So that activates the dendritic cell, and it goes around and around and around. And in a healthy immune response, we have ways of clamping that down. And in lupus, a lot of those ways are very defective, and so you get a vicious circle of inflammation. But the key here is that when it doesn't seem that there is enough going on with that B cell, and that the immune response feels like it's ineffective, at least from the interpretation of all the feedback loops that we have, just remember what that myeloid cell is going to do. It's going to make more bliss. And we've known that for a long time. We've also known for a long time that when you give rituximab, you get an elevated bliss. And the mechanism of that is not fully understood, but you take away those B cells, you're going to get an elevated production of bliss. And so here is sort of an illustration of that. And I have the CAR T cell driving in. But basically, we already know in the upper right-hand corner that you take away the B cell with that big orange X, and that myeloid cell is going to start making bliss. And so here's the question. If you take away even more of the B cells, will you get even more bliss? And why would I care? If I don't have a B cell, why do I care if there's bliss running around? Because bliss activates B cells, and if they're not there, how can the bliss cause any trouble? And so, of course, given the redundancies that have been divinely included in our immune system, of course there are other cells that have receptors for bliss. And here's sort of a story of what happens downstream from an activated B cell. So over there on the right, I've got a macrophage, and it's making a whole lot of bliss, and it's activating the B cell, and the B cell is differentiating because of that into a plasmablast, and the plasmablast is going to differentiate further into plasma cells and eventually what we call long-lived plasma cells. And in fact, many of our most vicious autoantibodies are being made by the long-lived plasma cells. Meanwhile, there's something called a T follicular helper cell, which is part of the T cell group, and it's coming in and interacting back and forth with the plasma cells, and a lot of cytokines are being made, a lot of inflammation is starting, and you can see over on the left side of that white line that we've got some bad players there, including IL-6, which we know is associated with some pretty severe inflammation. So there's a lot going on after you leave the B cell. And so here's the question. How long is CD19 there? Meaning, how many of these players are we killing when we kill B cells? And that line is kind of drawn there because CD19 goes away over on the left side of that line as these cells differentiate and change on their surface. So if you're going to deplete every single cell carrying CD19, you are not going to deplete all of those cells that are over on the left side of that line. And clearly, they are capable of causing trouble all by themselves if you don't kill them. as well as carrying a certain amount of just understanding and precedent into what they might recognize and what they might do. So when we talk about a reset of the immune system, it's very glib. We don't really know all the things that do and do not happen. Now, before everybody gets depressed, we have seen these remarkable stories of patients with incredibly refractory disease, unresponsive to major interventions, who have gone for 2 years or more with absolutely no immune modulating therapy after receiving CAR T cells. So it's still wonderful. And I'm not going to here to suggest to you that it isn't. I'm simply here to suggest to you that when you start to see all of the data coming out, that you think about, this is only, I'm giving you a sort of complex description of one single mechanism. There are probably others. Think about the fact that due to the complexity of what we're working with here, we still have to hang on to our knowledge as clinicians that the patients are not all like each other and they're not all going to respond the same way, because there's all kinds of other stuff going on in overlapping spectrum cohorts of our patients. So we do have some early data that we can see differences in what the immune system looks like after CAR T cell therapy is given, and has been, at least in one study, compared with what you see after the rituximab is given, and or belimumab. And so after rituximab and or belimumab, the CAR T seems to induce more downregulation of some of those signals coming from, remember that plasmacytoid dendritic cells and those interferon signals? There is a dampening of those that seems to be greater with the CAR T cells therapy than with rituximab or belimumab. Now, is this due to greater B cell depletion? We don't know, but there does seem to be something happening there that was not happening with those other agents. And also some of the cytotoxicity pathways that are induced by complement. So there just seems to be a greater immune dampening overall, interleukin-1 signaling and other chemokines. So, there is something different here. And in fact, even compared with cyclophosphamide alone, right, there's increased dampening of type 1 and 2 interferon pathways and signals and pathways consistent with oxidative stress, and downregulation of the mTOR pathway, which is a T cell activating pathway. So it's reverberating a bit more throughout the immune system, which makes sense because all the components of our immune system are talking to all the other components of our immune system. But here's what we don't know. And I'm about to show you, how you get a CAR T cell going in your body. It involves the addition of chemotherapy. So before you even give the CAR T cell, that patient has had a process called leukapheresis, where white blood cells are removed from the blood, which is a treatment for lupus, okay? And they've also received at least one dose of low-dose cyclophosphamide and fludarabine. So these patients are not just getting CAR T cells, they're getting some other potentially immune modulating agents as well. So how do we know that any of this has anything to do with a CAR T cell and not with the fact that it's been coupled to other immune suppressive signals? And then the other question is that we really have to ask if we want to be critical is, what if when you gave the belimumab or the rituximab, what if you gave a little induction chemo with them too? What would happen then? Would it really be so different? And we don't know the answer to that. So be a little critical when you see this data. When people tell you about CAR T cell therapy, they're telling you about the entire therapy, which may include other agents besides CAR T cells. Having said that, I don't care what they did, it's still very exciting that there are patients today who are walking around drug-free, very healthy, after 2 years or more after all of this was over. And we really haven't seen a whole lot of that in the past. I want to call your attention again to something I showed earlier in the meeting, which is that different types of background medications are setting our patients up differently when they're going to receive a new therapy. So, when you give CAR T-cell therapy, you're going to stop all the original medication that the patient was on. But when they come to the starting gate, like horses ready for a horse race, they haven't been treated the same way when they get there. And a lot of these patients are quite sick. And a lot of these patients have received quite a lot of aggressive medicine. And so when we start thinking about how do we figure out, which patients are going to respond to CAR T cells, let us keep in mind that they're not all starting with the same immune imbalances. And we have a lot to learn. And it gives you a headache. You go, how am I going to get my arms around all this data? Well, you know what? That's what AI is for, or just computers, or just mathematicians. So we do have the technology to begin to address these variables, turn them into recognizable patterns that human beings can understand, and start thinking a lot more clearly when we have new therapies about who did respond, who didn't respond, why, what else needs to be done, or was this patient just not a candidate? And these are variables that we could master. And we've gone nowhere to do that yet, but we could. And the technology exists. I want to remind you again also, something I showed earlier in the meeting, that the immune system is a Rube Goldberg machine, which is known very well to children who play the game Mousetrap. Depending on how hard you push it at any step in this complex series of one element pushing the next element, pushing the next element, pushing the next element, until finally over there on the right, you can trap a mouse because that you hit just hard enough, and that basket will come down and trap the mouse. Now, if you hit too hard at any point along the way, you're gonna break it apart, and you have to put the whole thing back together again. If you hit it too softly, the next element is not gonna get instigated. And then beyond that, our immune system has extra feedback loops all along the way, so that when you trigger certain people just right to get that mousetrap to work, something's gonna boomerang back at you. And it's different in individual people. And you may wonder, why is that? Why can't we all just have a perfectly working machine? And of course, you all know the answer to that. If we all had the same perfectly working machine, sooner or later, some pathogen would come along and destroy us all. And the reason why that has not happened in the history of humankind is because people's immune systems are all slightly different from each other, and it's ordained in genetics. So what we have is whack-a-mole. Hit too hard, and a mole is going to pop up, and you haven't won the game yet. Hit too softly, and you can't get the mole that's up there now to go down. So to get this beautiful situation where obviously this player has won the game and all the moles are in the holes, right? You have to really do a refined job. And we have the tools, and we do not understand them. So as we step into this CAR T-cell therapy world, let's keep in mind and be, a little modest, and realize that we really don't know what we're doing. And so that's why they invented the scientific method. And that's why they invented clinical ways of operating, where we work with those doses, we work with the patients, we try to figure out what we did or didn't do. And until we have better tools, this is going to require, to some extent, some trial and error, and to some extent, we need to be more mature in how we describe these things to our patients. I think it's true, and they're seeing it all over the media and the internet, that there are some remarkable results with some of these therapies, and it has been miraculous for some patients for up to and more than 2 years of drug-free remission. But that's not what's going to happen to every patient. And like we do always in our clinic, we need to have a reset, not just of the immune system, but of people's expectations. So what happens to Bliss when you give steroids? Here's the data. It goes down. Steroids actually, despite some dogma that was running around about 10 or 15 years ago, have a very high impact on the release of interferon, type 1 interferons, and also on bliss downstream from there, as we discussed. And here you see some patients who came in. All of them had active disease, although it was more like moderate to moderately severe disease. It wasn't really severe refractory lupus. And they were given intramuscular steroid shots, which are lovely treatments because if you want to be able to help your patient glide off their steroids without that awful, did I taper too much or did I taper too fast kind of business, these intramuscular injections are beautiful in how they sort of wean themselves off the patient without the patient having to, change the amount of pills they're taking and have that sort of psychological smack of, oh my gosh, I'm taking less, I hope I don't flare. It just sort of happens slowly. So they glide off, and because of that, you can kind of make kind of a semi-scientific analysis of what happens. And you can see that, the bliss goes down, and then it recovers. And I'm not going to belabor this too much, but if you go over to the y-axis and you try to track any of these individuals, what you see is that most of them, when they recover, the bliss comes back pretty much to where it was before. And that's usually around the same time that the steroids wear off. So we're kind of showing a little bit of an analogy to what we're talking about with CAR T cells here. But remember, the initial thing that happens here is there is improvement in the bliss. So what does happen with rituximab and CAR T cells, specifically with bliss? There isn't a whole lot of data on that. But on the left here, we're looking at patients with TTP who received rituximab. And if on the left of that first graph are healthy controls, and then next patients before they get treated with rituximab, and then after they get treated. And you can see on the y-axis, we're looking at the bliss levels. And I just want to point out to you that here we're talking about, let me make sure I'm right about that, nanograms per mole. So when you're talking about nanograms per mole, your numbers are going to be more like 1, 2, 3, 4, 5. And if you can squint, you can see that's exactly what's on that y-axis. So in the middle, we're looking at people with asthma, and they've been treated with rituximab, and you can see that their bliss goes up. And so on the left of each thing is the patient who got treated, and the bliss has gone up. And so we don't see it really going down. There's not much time because very early after you treat with a B-cell depleter, I like to think of it like this, although obviously this is not a very scientific way of looking at it. I like to think that the myeloid cells are going, hey, where are the B cells? Oh my gosh, make some bliss, But it happens pretty early. And we don't have a whole lot of studies that tell us how early or what the timeline is of that. But we do know that if you make a lot of bliss, that's kind of something you got to do before the B cells come back. So what about CAR T? Do we have any data? Just a tiny bit of data. And here we're looking at big numbers there, 5,000, 1,000, but don't get too excited about that because 5,000 is in picograms per mole, and it would be equivalent to where you see a 5 over there on the left-hand side of the graph. But having said that, let's look at those numbers again. So, elevated bliss with rituximab is in the sort of 4 range, less than 5 range at the max, the maximum amount you see. But when you look at the 5,000, which would be equivalent to that, over there on the right where someone got CAR T cells, you've got that orange patient represented by an orange line. They're starting close to that number. They're starting pretty much close to where that elevation was with rituximab. And the other patients aren't. They're starting a bit lower, like you'd expect. But look at that blue patient, goes way up, much higher than you're seeing with rituximab. Now, can we draw conclusions from that? Of course not. This is very early data, but you're seeing it very early. So keep your eye out for what these CAR T cells do to bliss. But the hypothesis would be you're going to get more bliss because you're going to have a lot less B cells. And I'm going to remind you down at the bottom, that same picture you saw before, there is a potential, and it's not just theoretical, there's data to support it, that if you have a lot of bliss, there are elements in the immune system that are going to be activated whether or not you killed all the B cells. So let's get back to our patient with thrombocytopenia who received a pretty standard CAR T-cell protocol. So it starts out with up at the top, and we're going to go to the right because the first thing that happens is leukapheresis. And so that's a treatment for lupus, isn't it? But you need those cells because they're going to be transferred to a manufacturing site, and they're going to isolate the cells that they want, which are T cells, and then they're going to integrate the CAR, chimeric antigen receptor, CAR. They're going to integrate that gene into the patient's cells and teach them that they're going to target T cell. They're going to target themselves to CD19, which is on B cells. So the target is B cells, and the killer is being made out of transforming cells that came from the patient's own body. And that takes a while. They use a viral vector. They have to cook it. They have to stir it up. They have to stir the brew like a witch. And eventually they have to show, that these are functional cells. This takes weeks sometimes, although there are newer agents and newer techniques that are doing it a little more rapidly these days. Keep your eye out for that. And then they have to be stimulated and expanded, and then you got to take them back to the clinic. And then the patient's got to be there, and they've got to get their infusion. But because there's a real concern and consideration about the fact that they may attack these cells, because even though it's their own cells, it's been transformed and there's some strange things on it, something we have been taught from as soon as we got our own immune systems to look for. If any of our cells get transformed, we're supposed to attack them. What if it's a cancer cell? Get rid of it, right? So you got to suppress the immune system to start off so that these cells can get in there and do their thing before they do die off. So before the transfusion is given, patients receive cyclophosphamide and fludarabine. That is the usual protocol, and then they get the CAR T-cell therapy. So cyclophosphamide and fludarabine are treatments for lupus. So they've already gotten treatments for lupus. It's not like they sat there the entire time with nothing happening. You also have to stop their background medications, and that's sort of in the protocol that let's just see what we can do now, let's see how we can do this. Our patient with lupus, immune thrombocytopenia, had outstanding results at 6 months. And so there was apparently, at least as well as we can measure it, there was an apparently complete B-cell depletion, and there was a complete abrogation of antibodies to that platelet adhesion factor, GP2B3A. Complement levels normalized. Platelet counts went to greater than 100,000. And interestingly, there was no change in lupus autoantibodies. Particularly SSA-Rho is very refractory to any treatment known to man. It's always there, whether the patient's well or bad. And the speculation about that is that it's being made by long-lived plasma cells. Remember, those were the guys, they don't even have CD19 on their surface. So why would they respond, except maybe temporarily to chemo, but probably not enough chemo from our own experience as rheumatologists to keep that, away. So this patient had a fabulous result, and this report, I believe, followed them up to about 6 months, or maybe even a little more, because I've got some greater thans there. But remember, we still don't know for sure out at 6 months whether we might not have received the same response if we had added chemo, leukapheresis chemo, which included fludarabine, to rituximab. And I want to point out to you that early in the process of our learning to give rituximab in the first place, a B-cell depleter that we also stole from hematology, we used to give chemo with it. And the early anecdotal case series that didn't have placebo control groups, particularly those that were reported by David Jane of Oxford University, who is a meticulous clinician scientist, and early reports of many patients with lupus nephritis were following them out quite a while with complete remissions also. So we're not sure yet. It looks good, but we're not sure yet. I was just going to underscore here that autoantibodies are still there, so we didn't reset the immune system to total normality. On the other hand, there are a lot of healthy people walking around with ANAs and anti-SSA-RO. So we also don't know that we didn't do something dramatically wonderful here. Here's some data from one of the early studies done by a pharmaceutical company. And the reason why I want to show you this, it's very early, it's just an anecdotal series of 4 patients. The reason I want to show you this is that they found the same thing. They were able to, on the right of each graph, and these are each a patient with, refractory lupus. SLE1, the first patient, had class 5 nephritis, but they were characterizing them as a non-nephritis patient. That was their choice. And also had, as you see all the colors there, these are all the manifestations that were scored on the SLE-Day. And really was a dramatic improvement for this patient, similar to what I'm describing, where they were off their meds and doing very well. And what's left? What's left were anti-DNA antibodies and low complement and some proteinuria, but the proteinuria had gone down. And class 5, they're way up there, so it's going to take a while to come down. The second patient got rid of their major manifestations and were left with anti-double-stranded DNA and low complement. And then finally, there was the third patient, and they were left with anti-double-stranded DNA. But the clinical manifestations had all gotten better. And here's their nephritis patient who had proliferative nephritis. And you can see that that patient had been very ill and came in, all these colors represent a different symptom. Came in with all these different things, and it all went away except for a little alopecia, a little rash, and proteinuria. But over on the left side, you can see what happened with the proteinuria in this patient. It came dramatically down, and what it's doing there right at the end, at the last visit, is it's hovering just above the cutoff for scoring proteinuria on the SLE-Day. I think as clinicians, we'd all be very happy to see this if we had a very refractory patient, but on a technicality, it had to be counted. And this is what I really want you to watch out for. How meticulous is the reporting? And one of the things that I'm going to say this, I don't know if it's fashionable to say this. It's probably unfashionable to say this. But when you see data from academic centers, nobody's watching, nobody's monitoring, nobody's proving to the regulatory authorities that they're doing it right. But if you are a company, you have to do all of that diligence. And personally, I trust drug company data in clinical trials. Trust, I mean, you should never trust anything, but I have more confidence in it than I do from reports from academic centers, including my own. So I've done my own trials, and I can't see all the patients, so somebody else is seeing the patients. And I go in and monitor it, and there's all kinds of disorder because these are busy clinicians in their clinic, they're trying to do 15 things, and then they want to do a little research. Be careful, because a company trial has, these companies are hiring copious numbers of people to make sure that it stays on track and everything's queried and neatly reported, and that no stone gets left unturned because their livelihood depends on it. So I want to show you company data, and I do it. It's what I do, because I think that we should keep in mind that although we should be skeptical of everything, of course, we should be skeptical of everything. It's our job. But keep in mind that data from academic centers is not all that well monitored. Now, what about adverse events in lupus with CAR T-cell therapies? Well, we knew what they were likely to be from quite a lot of data from oncology. And so it's very common to see cytokine release syndrome, fevers, organ dysfunction, seen with lots of immune therapies, but really quite prominent with CAR T therapies. And we also know it's relatively rare to see severe cytokine release syndrome from these therapies, but it does happen. And then there is a high incidence that may be overreported of mild symptoms that are really kind of unknown significance, and some of those are being reported as cytokine release syndrome. But when they are, these tend to be reversible and manageable conditions. The real risk in lupus is unknown, but our experience to date, and I'll show you what data we have in a minute, that it's common to see mild cytokine release syndrome. We're just not seeing anything very severe. And you can speculate that there may be less volume of dead and dying cells in a lupus patient than in a patient with lymphoma, where you're killing those cancer cells directly. And then there's a condition called immune effector cell-associated neurotoxicity syndrome, or ICANS. And this is a scary neurological syndrome, which can, again, occur with any immunotherapy, may or may not accompany cytokine release syndrome, is reversible, will get better, so supportive management can be helpful, but it's something you really don't want to get. It's very scary. We see cytopenias and hypogammaglobulinemia. There are serious infections reported. And then there's a very rare report, or 2 or 3 or 4 out there, where the chimeric antigen receptor cell becomes a cancer cell itself. And that's like really scary because we made that cancer. But again, it's quite rare, and depending on how sick your patient is, as we do in lupus all the time, we have to weigh the risks and the potential benefits. So in lupus, I'll show you the data now. This is what we know about how this is working out for us. So this is a review that was just recently published by Anka Askanase and her group. And they looked at a series of papers reporting data from autologous CAR T-cell therapy, which is sort of what we're talking about today, and also 4 papers describing allogeneic cell therapies, which is, we'll get to that in a minute, but these are kind of cool because instead of taking the patient's cell and making them wait while you go to the lab and turn them into transformed CAR T cells, these can just be made off the shelf and given to patients. And there are issues with them because it's not known if they will live as long or be as effective, or get more attacked by the immune system, and all kinds of strategies, because we're so smart these days, have been made to make them, better able to get in there, be tolerated, and live a little longer. So we're going to see what happens with them. But anyway, this covers a total of, I have to do this because I can't see the edge of my slide, 145 participants with lupus. That's quite a few now. We're collecting quite a few of these anecdotal reports. Basically, about 70% of them went into something called DORIS remission, which is just a clinically defined state of very low disease activity. And then LLDAS is a little less stringent than that. That's lupus low disease activity state. And 89% of them achieved that. And 84% of them were able to achieve a drug-free remission. But as you can see from the graph, these patients have been followed for varying amounts of time. And so basically going out to about a year in these series. So what happened with the side effects? In 56% of the patients, there was cytokine release syndrome, and most of them, almost all of them, were lower grade cytokine release syndrome, and this is reversible. And they had 1 report of ICANN, this neurological toxicity, 1 each, So one grade 1, which is low grade, one grade 2, which may involve a little bit more toxicity, one grade 3, and one grade 4. So there's been one really serious one. And then there were serious infections, and there was one fatal pneumococcal meningitis, but these are not really out of the realm of what we see in most lupus clinical trials if you had 145 patients. So all in all, the toxicities seem to be not making us run screaming away. So far, so good. But you'll notice that as you follow these patients all the way out to a year, some of them are flaring up. Some of them are flaring up as early as a little bit after 6 months. And if you look and you squint really hard, we have some early flares too. So not all of the patients are just taking this magical potion and coming out, perfect and on no drugs and cured, throwing away their crutches and things like that. But you can see this is a very good result. We get good results. So I'm going to contrast to this the reports that came out of Germany originally. And I think this bears a little bit of scrutiny. So these are reports from Erlanger, Germany. And in their first paper where they described the use of CAR T cells in an anecdotal case series in patients with several autoimmune conditions, it included 8 patients with lupus. And the follow-up ranged from 6 to 29 months. So they had some long-term follow-up on some of these patients. And some of the early dramatic reports were coming from here. 100% of their patients reached lupus low disease activity state. Well, there were only 8 patients compared to 145, and you saw the data. That's possible. We can believe that. And 100% of them got a SLEDAI of 0. Well, that's hard to do. 100% of them met that other stringent DORIS remission, and 100% of them stopped their immune therapy. And they don't really tell us whether any of those 8 patients received any steroid. It is simply not reported. We do know from their protocol that you were allowed to give steroids if you needed to for more severe cytokine release syndrome or, as you needed, maybe for ICANN if it happened. But we do know that 3 of their patients received tocilizumab, which is given for side effects. Tocilizumab is a treatment for lupus. So let's summarize all the treatments that have been given to these patients. 100% received pheresis in order to make the CAR T cells. 100% received fludarabine and cyclophosphamide. And 37% got tocilizumab at some point in the course of this. And so you can kind of see of those 8 patients down here in that graph, you're kind of seeing how far they were able to follow them. And so if you look, you can see only one of them dropped out at 6 months, and everybody else was followed for at least 12 months. And from there, you can sort of see as they drop out with those little triangles. Now, what's with the proteinuria in that one patient? What was that? If 100% got drug-free remission, what happened to the proteinuria in that patient? Well, it was explained, and this was presented at EULAR, and some very polite European doctors got up and said, could you explain the proteinuria going up in that patient? And the response was, oh, that wasn't lupus. That was podocytopathy. And then the entire room went, because, of course, lupus patients get podocytopathy. All that is a kind of a pauci immune, there's cells, but there's very little autoantibodies out there. And it happens in the context of patients who have or have not had nephritis. There's massive proteinuria, and it's a damage to the podocytes. And if you ask nephrologists, you can see that without lupus, but you can also see it with lupus. And you know the rule. If the patient has lupus and it's seen in lupus, it must be due to lupus. But they did not agree, and they reported as no lupus flares. They also reported that anti-double-stranded DNA in C3 normalized in all of the patients, as did all autoantibodies, including anti-SM, except for anti-Rho. Now, the mean duration of the B cells being gone was about 112 plus or minus days, very comparable to rituximab. So what we weren't seeing, and we aren't seeing in any of the other reports, is a prolonged B cell depletion. So the issue is, are we getting deeper B cell depletion, and how does that translate? All right, let's follow those patients from Erlanger because they've been reported again, incorporated into a larger series. We know they're in there because that podocytopathy patient is described again. And here, 2 centers have been reporting their combined patients. Now some of them from Erlanger have been followed for even longer. And at the bottom, we're looking at the second study where we're now, how many did we get here? We now have 20 patients with lupus, and the shortest follow-up here is greater than or equal to 30 days. All right, so now 18 out of 20, so it's no longer 100%, achieved lupus low disease activity state. 11 out of 20, so it's no longer 100%, achieved a more deep DORIS remission. And 4 out of the 20 achieved a SLEDAI of 0. So suddenly, the reporting is very different than those first 8 patients. Now, is it very different, or is something being interpreted differently? That's not clear. And they don't address that either. So 38% received steroids, which was not reported in the first 8 patients. And 65% have now received tocilizumab. And again, of course, 100% received pheresis, 100% received fludarabine and cyclophosphamide, 65% got tocilizumab, again, as I mentioned, and 38% got steroids. And that, we have to understand, is the context in which we're looking at these remissions. That is not to suggest to you that it isn't wonderful that we know a number of patients have gotten out to more than 2 years with drug-free remission, because at that point, they're not getting all of this stuff, and their background meds have been stopped. This is not to suggest to you that we should not be excited about CAR T cells. What it should suggest to you is we need to be critical about the data as it comes out and question it really profoundly. Because it turns out that in this series, which included the original 8 patients, it is not true that there were no lupus flares. And let's not even talk about the guy with podocytopathy. What they have decided to do is describe a new condition called local immune effector cell-associated toxicity syndrome, or LICATS, and this was published in Lancet Rheumatology just a few months ago. And it turns out that what's happened is that if you came in with arthritis and you got this strange new diagnosis, a strange new thing, it manifested as arthritis. If you came in with proteinuria and you got this, it manifested as proteinuria. If you came in with rash, it manifested as rash, and some of the patients had more than one of these manifestations occur. The reason why it was not a lupus flare was because it happened when the B cells were gone. Well, I think I have built up our expectation that bad things can still happen when the B cells are gone due to relationships between immune effector cells and cytokines that we do know about and that can be explained. So this was a transient occurrence, and many of them were treated with steroids, which is why we're suddenly seeing these steroids being reported. So it turns out that I'll just leave lupus for a minute because this also occurred in patients with myositis, and when it returned, it manifested as myositis. So what we're looking at here is people sort of having clinical recurrences of their disease, which is being ascribed to some new phenomenon that's not their disease, all of these manifestations did occur in previously involved organs. In other words, these were lupus flares. Remember, we gave one plausible explanation of why you could get a lupus flare after you depleted all your B cells. This is not the only possibility, because we have such an enormous complexity in our immune system with all kinds of checks and balances and boomerangs, as I said before, that we should not be surprised that you can get lupus flares after CAR T therapy. And please understand that this does not mean we shouldn't be excited that many patients have gotten out to 2 years with drug-free remissions, because when this is all over and it's been treated with steroids or whatever you're going to treat it with, or maybe even resolved on its own, as some of the milder ones did, we still got a great result. It's just that when we see data, we need to be critical, and data needs to be monitored. And that is the evidence that I'm using to you today, that we might be a little bit more confident about data being reported from poor companies who are subjected to so much scrutiny, but at least we know everything is being reported. Now, clearly, some of this may have been caused by us and by our therapy. And we know that. We know from that data that said a higher dose gets you less efficacy than the lower dose. So can we stay one step ahead of the problems that we cause? And the answer is, oh my goodness, there's so much new technology out there. We've got cell therapy being developed right now using natural killer cells with all kinds of potential advantages. We've got CAR T cells that target some of the very antigens over on that side of the white line that I said we weren't hitting with anti-CD19. We've got CAR T cells where one CAR T cell is hitting more than one antigen. There's just all kinds of things you can do. You could come up with cocktails individualized for the unique pathology of some patient with lupus. And down at the bottom there, I just put 3 good CAR Ts together, all in one T cell. All those chimeric antigens can be in one T cell. That is now technically possible, and people are working on such things. Of course, once you get too many of these put together, and try to make sure you're hitting everything possible that you need to balance the immune system of one individual patient, you may need a new form of transport for these cells. So you may also want to ask yourself, why not just give steroids, because we hit everything with steroids, or cyclophosphamide. But somewhere in there may be a sweet spot where we're playing the immune system like a piano, and resulting in a symphony. Where we can really make people feel better, maybe even prevent some of our more low-grade diseases that are, after all, big killers, such as atherosclerosis. Now, there are procedural concerns with CAR T cells. Patients with lupus might be very ill. They're requiring withdrawal from immune suppressants. They're requiring they have to wait 3 weeks or more while a CAR T is being manufactured. After you do all that, you can't guarantee that that manufacturing process will succeed in all cases. There may be side effects from the immune depletion, and the insurance may not cover such an expensive treatment. So just to let you know briefly, there are cheaper and safer ways, potentially. We don't know that they're safer because we haven't got the data yet, but potentially safer ways, strategies towards safer ways to combine the specificity of an antibody with the potent versatility of the cell. And here, I'm not going to spend much time on this, but we've got the CAR natural killer cells, and then out from there, we also are seeing the emergence of some fascinating therapies. They really are cell therapies, but they're just antibody-type things, or linker-type constructs. And they're bispecific, so what they'll do is they'll find the T cell, and they'll hang off the T cell until they find the B cell, or whatever your target cell is. And they'll bring your own unadulterated, unmodulated T cell out to the target and potentially have the same deep penetration as a CAR T cell. would. We don't know for sure how that's all going to play out, but this is all on the horizon. It's coming soon. And our biggest problem right now is we can't find enough lupus patients to be in all of these trials. So, in summary, this is exciting. And this is theoretically a huge breakthrough. We really don't know what we're doing. And we really must be critical of the data. But step one is to recognize what it is that we actually have. Thank you.
Our microphones, if people have questions. Dr. Merle, I think you answered everything.
Well, I don't know how tired you are, but this was quite a meeting, so I'm a little tired.
But we thank you very much. It was very thorough.
Thank you.